Welcome to our deep dive today, folks.
Yeah.
We're going to be looking at cariology.
Yeah.
And I know we talk about this all the time, but I think it's one of those topics that we can never get enough of
Absolutely.
and can always be refreshed on. And we're lucky enough to have a real expert in the field with us today, so welcome.
Thank you. It's a pleasure to be here.
Yeah. So before we dive in to all the details, maybe just give us like a high-level overview of like what exactly is cariology. What are the things that we should be thinking about?
So I think, it's one of the fundamentals of dentistry. We all know it.
Yeah.
But it's very easy to forget about it. We kind of take it for granted sometimes. But it's a dynamic process. It's an infectious disease.
Yeah.
And it's a demineralization process of the hard tissues of the teeth.
Right. And I think it's so easy to just be like, oh, it's just cavities.
Yeah.
But it's obviously way more than that.
Exactly.
It's like a whole process.
Exactly.
And I know that you've talked about before, like classifications of caries. And I thought that was really interesting because, again, we think of it as just one thing, right? It's like, oh, there's decay, but there's actually different types.
Absolutely. So, just to give you an example, we've got chronic caries.
Right.
Which, as the name suggests, is chronic. It takes a long time to develop.
Yeah.
Versus rampant caries.
Right.
And that can be very, very quick, especially in children.
Right. Right. And then also, like, I remember you talking about forward versus backward caries.
Yes.
And I'd never even heard of that before.
So forward caries is the typical progression of caries from the outside surface in, whereas backward caries is kind of like a lateral spread of the caries under the enamel.
Wow.
And so that's something to bear in mind.
So sneaky.
Exactly.
And I guess that also ties into how we diagnose these things.
Yeah.
Because you're saying it could be happening and we don't even see it on the surface. So how do we diagnose? I know that we've got the traditional methods, right? The X-rays, the looking with our Explorer.
Exactly. We've got our visual exam, we've got our tactile exam, and we've got our radiographs. But they all have their limitations.
Right.
For example, with radiographs, we can't really see interproximal caries very well. We can't see early lesions very well. So that's where some of the newer technologies come in. Things like diagnodent or fiber optic transillumination can be helpful.
Right. Right. Yeah. I've heard about diagnodent. I haven't really used it that much.
Right.
But like, how does that even work?
So diagnodent uses laser fluorescence to detect changes in the density of the tooth structure.
Okay.
So if there's demineralization, it will give you a higher reading.
Oh. So it's like more sensitive than just
exactly an adjunct to your clinical exam.
So we've talked about diagnosis, we've talked about different types of caries. Now let's actually get into the tooth.
Okay.
So when we talk about like dental caries, what is that? Like, how is that different?
So basically when caries progresses through the enamel, it reaches the dentine. And the dentine has these tubules, which are like little channels that run from the pulp to the outer surface of the dentine. And there are 5 zones of dentinal caries. Zone 1 is normal dentine, which is unaffected by the caries process.
So that's like the healthy dentine.
Exactly. And then as the caries progresses, we get to zone 2 and zone 3.
Okay.
Now, these zones are affected by the caries process, but they're not infected yet.
Okay.
So there's still a chance to remineralize these zones.
Oh, interesting. So even though it's like starting to get demineralized, we can still bring it back?
Exactly. So it's important to catch it at that stage.
Yeah, for sure.
However, if the caries progresses further, we get to zone 4, which is the turbid dentine, and zone 5, which is the infected dentine.
Oh.
Now, in these zones, the collagen structure of the dentine is irreversibly damaged.
Okay.
And the bacteria have invaded the tubules. So in these zones, we need to remove the infected dentine.
Right. So it's like a battle, right?
Yes.
The first couple of zones, it's like, okay, we can still win this.
Exactly.
But then once it gets to the later zones, it's like, okay, we need to take action.
Exactly.
Take more drastic action.
We've got to remove that infected dentine.
This is fascinating. So I guess the question then becomes, like, how do we decide how much dentine to remove? Like, when do we stop?
That's a great question. And that's where clinical judgment comes in. There are different philosophies on this. Some clinicians advocate for removing all the affected dentine, even if it's not infected, whereas others believe in selective removal, where we only remove the infected dentine and try to preserve as much of the affected dentine as possible.
Interesting. So there's not like a one-size-fits-all answer.
Exactly. It depends on the individual case.
Right, right. So we've talked about the dentine. We've talked about these different zones. We've talked about diagnosis. What else? what other things should we be thinking about when we're talking about cariology?
So I think another important thing to consider is hypersensitivity. You know, a lot of patients complain of sensitive teeth.
Right. Yeah, for sure.
And that's basically due to exposed dentinal tubules.
Okay. So like if the enamel's worn away or something.
Exactly. Or if there's gingival recession.
Gotcha.
And the hydrodynamic theory explains this. Basically, when there's a stimulus like cold air or cold water,
right,
it causes the fluid in the tubules to move, and that stimulates the nerve endings in the pulp.
Interesting. So it's like, it's not just like the cold hitting the nerve, it's actually causing movement in the tooth.
Exactly. It's a hydrodynamic phenomenon.
That's wild. Okay. So how do we manage that then? If someone comes in, they're like, oh, my teeth are so sensitive.
So there are a number of things we can do. We can use desensitizing toothpastes, which contain ingredients like potassium nitrate.
Okay.
We can use fluoride treatments, which help to remineralize the dentine.
Right.
And we can also use bonding agents, which basically seal the tubules. In more severe cases, we might even consider using lasers or other more invasive techniques.
Interesting. Interesting. So lots of different options depending on the severity.
Exactly.
Wow. This is, I mean, we've only just scratched the surface, but this is already so much information.
It's a lot to take in.
I know.
So I think maybe we should take a little break here.
Yeah, for sure. Let's let everyone digest this.
Yeah.
And then we'll come back and keep diving deeper.
Sounds good. So are you ready to keep going?
Yeah. Let's do it.
Yeah.
I'm ready to go deeper into the tooth. Let's talk pulp.
Okay.
I feel like that's where things really start to get interesting. Or painful, depending on the situation.
Yes.
So what are we talking about when we talk about pulpal lesions?
So pulpal lesions are basically any damage to the pulp tissue,
right,
which can be caused by a number of things like Burtesies, trauma, or even just wear and tear.
Okay, so it's like the nerve of the tooth is getting affected.
Exactly. And the pulp is very sensitive.
Right.
So any damage to it can cause pain.
Yeah. And I know that we've talked about reversible and irreversible pulpitis.
Yes.
And I've always found that distinction really interesting. Like, how do we know when it's crossed that line from reversible to irreversible?
Yeah, so reversible pulpitis is basically inflammation of the pulp.
Okay.
It can be reversed if the cause is removed.
Gotcha.
So, for example, if you have a deep cavity that's causing pulpitis, once you remove the decay and place a filling, the pulpitis should resolve.
Okay, so it's like it's irritated.
Yeah.
But it can calm down.
Exactly.
If we take care of the problem.
Yeah.
Okay. So then what about irreversible pulpitis? Like, what's going on there?
So irreversible pulpitis is basically when the inflammation has progressed to the point where the pulp can no longer heal itself.
Okay.
So even if you remove the cause, the pulp is going to die.
Gotcha. So it's like it's gone too far.
Exactly.
Okay. So how do we know? Like if a patient comes in, how do we know which one it is?
So there are a few key differences between reversible and irreversible pulpitis.
Okay.
With reversible pulpitis, the pain is usually sharp.
Okay.
And it's provoked by a stimulus, like cold or sweets.
Okay.
And once the stimulus is removed, the pain goes away quickly.
Right. Right. So it's like a quick, sharp pain.
Exactly. Whereas with irreversible pulpitis, the pain is often more spontaneous.
Okay.
And it can linger for a long time, even after the stimulus is removed.
Oh, so it's like a constant throbbing kind of pain.
Exactly. It can also be worse at night.
Okay. Yeah, that makes sense. That makes sense. So then I guess the question becomes, like, how do we treat these things? Obviously, if it's reversible, we try to save the pulp.
Exactly. We want to try to preserve the vitality of the tooth.
Right.
So we'll remove the cause of the inflammation and place a sedative filling.
Okay.
And then we'll monitor the tooth to make sure the pulpitis resolves.
Okay. But if it's irreversible?
If it's irreversible, then unfortunately we need to remove the pulp.
Right. So we're talking root canal.
Exactly. Root canal treatment or extraction.
Okay. And I know, I mean, we've all done tons of root canals.
Yeah.
But I feel like there's always something new to learn. Like, what are some of the things that you think about when you're deciding what kind of root canal treatment to do?
So there are a few factors to consider, like the extent of the infection.
Okay.
The anatomy of the tooth.
Right.
The patient's overall health.
Yeah.
And even their preferences.
Right. It's not just like a one-size-fits-all procedure. It's like every tooth is different.
Every tooth is different. Every patient is different.
Okay. So speaking of things that can be tricky.
Yes.
Let's talk about post-restoration pain.
Yeah, that's always a fun one.
Yeah, because sometimes you think you did everything perfectly, and then the patient comes back and they're like, it hurts.
You're like, why? What did I do wrong?
Yeah, exactly. So what are some of the reasons why a patient might have pain after a